السلام عليكم ورحمة الله وبركاته. I'm Dr. Ammar Nouri. We will start with anesthesia lectures. Today we will start with the first lecture. What's the meaning of the anesthesia? Anesthesia means loss of sensation or absence of sensation. Here we have a brief history about the development of anesthesia. Anesthesia care can be involved the following steps. It include perioperative management, which is divided into preoperative management, intraoperative management, and postoperative management. Preoperative management: in any operation, patient must be seen preoperatively by the anesthetist in order to first take good history and physical examination and check the patient investigations, determine the fitness for anesthesia and surgery. Second, instructions about fasting time, which medication to continue at the of operation and which to stop, and tobacco smoking. Third, postpone elective surgery if patient is not prepared. Fourth, identification of risk factors and determine its severity and discuss the risk with the surgeon and patient with signature of consent form by the patient, of course, and by his relatives. Planning of anesthesia technique, whether general or local, with suitable premedication regarding the condition of the patient. In history, we ask for medical problems, current and past, previous anesthesia and related problems, family anesthesia history, allergies and drug intolerance, medications, alcohol and tobacco. Review of systems include snoring and fatigue, and lastly, exercise tolerance and physical active level. In examination, the minimal required examination is airway, heart and lung, vital signs including oxygen saturation, height and weight. In airway examination, we see the teeth and bite, the ability to protrude lower incisors beyond upper, which is called the mandibular subluxation, mouth opening or inter-incisor distance, normally more than 5 centimeters, Malambati score, facial hair, thyromental distance, which is normally 7 centimeters, length and thickness of neck, and range of motion of head and neck. Malambati score. The Malambati score means the assessment is performed with the patient sitting up straight, mouth open and tongue maximally protruded, without speaking or saying ah. It's divided to 4 classes. Class 1, it's most easy, expected for airway management. We can see soft palate, uvula, fauces, and pillars. Second class, or class 2, we can see soft palate, uvula, and fauces. The third class, we can see soft palate and base of uvula. Fourth class, which is expected to be a difficult intubation, only heart rate is visible. Elphosis is the arch opening at the back of the mouth leading to the pharynx. Here we have a picture of Malambati score, class 1, 2, 3, and 4. Investigations. Patient with no systemic disease and below 50 years, we ask for HB, sugar in urine, and viral study. Patient with no systemic disease and above 50 years, we ask for HB, sugar in urine, viral study, chest X-ray, and ECG. More investigations according to the affecting system if the patient has any medical disease regardless the age. Instructions to patient. Instructions regarding the fasting time. We have to stop heavy meals at least for 8 hours before surgery, a light meal up to 6 hours before surgery, and breast milk we have to stop it up to 4 hours before surgery, and the clear liquid, just like water, we have to stop it 2 hours before surgery. 2 hours of pre-anesthesia, nothing permitted. Instructions to the patient regarding medication that must be held or stopped and optimal duration of stop tobacco smoking. At day of operation, their stomach drugs must be continuous to the day of operation, just like diuretics, unless in severe heart failure and thiazides for hypertension. Oral hypoglycemic agents must be stopped at day of operation because the patient is coming fasting. Vitamins and iron. Angiotensin converting enzyme inhibitor or angiotensin receptors blocker. This stopped at day of operation. 2 days before operation, we have to stop the non-steroidal anti-inflammatory drugs. 4 days before operation, warfarin and convert to enoxaparin. Enoxaparin is the low molecular weight heparin. So duration of action is 24 hours. So we shift warfarin to enoxaparin and stop enoxaparin 24 hours before surgery. 7 days before operation, we have to stop clopidogrel or Plavix, aspirin, and herbal remedies. Herbal remedies just like garlic, which has the same effect as aspirin. Regarding tobacco, smoking must be stopped 4 weeks before the operation. Postoperative elective surgery or postponed elective surgery if patient need time for optimization, patient by adding or removing medication, or sent for medical consultation. Of acute like acute chest infection, or chronic like uncontrolled DM or hypertension. We also have to postpone elective surgery if need more investigation or does not prepare the blood if the surgery type need intraoperative blood transfusion or recent food ingestion or refuse to sign informed consent or MI within less than 6 months. Risk factor identification. We have two types of risk factors. First, patient-related risk factors and surgery-related risk factors. In patient-related risk factors, history of severe cardiac disease like ischemic heart disease, myocardial infarction, and cardiac failure. Severe respiratory disease like chronic obstructive pulmonary disease and respiratory failure. Age above 70 years with limited physiological reserve in one or more vital organs. Metabolic disease like renal failure, poorly controlled diabetes, morbid obesity, late stage vascular disease, and poor nutrition. And surgical related risk factors like prolonged duration of surgery, like more than 1.5 hours, extensive surgery like esophageectomy and gastrectomy, type of surgery, thoracic, abdominal, vascular, it's considered as high risk factor. Emergency surgery, perforated viscous, gangrenous bowel, gastrointestinal bleeding, acute massive blood loss, more than 2.5 liters of blood loss, it's considered high surgical risk factor. Septicemia, positive blood culture or sepsis, focus. Severe multiple trauma, example, more than 3 organs or 2 systems or 2 or more body cavity open. We have many scales to determine the risk factor. First, ASA grades, which is the American Society of Anesthesia, which is simple, related to operation mortality, not take to account the age, nature of surgery, and born to user interpretation. It can divide it into 5 stages or grades. Grade 1, the patient is healthy. The mortality rate is 0.1%. Stage or grade 2, the patient has mild systemic disease or functional limitation. Mortality rate is 1%. Grade 3, patient has severe systemic disease and defined functional limitation. Mortality rate is 4%. Grade 4, patient has severe systemic disease, constant threat to life, and the mortality rate is 20%. Grade 5, a patient is morbid, unlikely to survive 24 hours with or without operation. The mortality rate is 90%. The letter E is written beyond the grade of this classification and indicate emergency operation. In this schedule, we find that even the patient is healthy, like in grade 1, there is a % of mortality rate. The second scale is the metabolic equivalent task, which measure the exercise tolerance related to daily activity. 1 MET equal to 3.5 ml of oxygen per kg per minute. Oxygen consumption by 40 years, 70 kg man at rest. And patient who can exercise at 4 METs or above have lower risk of perioperative mortality. For example, 1 MET, the patient can just eat and dressing. 4 MET, the patient can climb 2 flights or stairs. 6 MET, the patient can do short run. Above 10 MET, the patient is able to participate in strenuous sport. The third scale is the reverse cardiac risk index, which is used to predict cardiac risk for non-cardiac surgery. Risk factors in this scale: history of ischemic heart disease, history of compensated or prior heart failure, history of cerebrovascular disease, diabetes mellitus, renal insufficiency, in which creatinine is more than 177 millimole per liter, and high-risk surgery. In this schedule, we have the relation between number of risk factors and risk major cardiac complication. If the patient have no risk factor, risk of major cardiac complications 0.4. Number has one risk factor, the risk is 0.9%. The number patient has 2 risk factors, risk is 7, and 3 and more risk factors, risk of the complication is 11. Anesthesia strategy is put a plan according to patient medical condition. Also, type of surgery must be taken in consideration, and this strategy started from the preoperative period, like prescribing pre-medication, or sent for more sophisticated investigation or optimization of the condition if the surgery is not so urgent. Passing through intraoperative period, like the use of invasive monitoring or determination which is the best to give general or local anesthesia, and it ends with the post-operative period, in which like preparation of ICU bed or oxygen therapy or analgesia plan for the post-operative period. Pre-medication objectives. Why we give pre-medication? First, sedation, alleviate anxiety and amnesia, to reduce risk of reflux, to manage pain, to control perioperative cardiac risk, dry secretion, and to decrease anesthetic requirement. But pre-medication is not suitable to all patients and must be prescribed after careful assessment of the patient. Examples of anesthesia strategy. First example, we have patient with ischemic heart disease associated with high risk mortality. And we said we divided the periods of anesthesia into preoperative period, intraoperative period, and postoperative periods. In a preoperative period, we do optimizing oxygen demand supply ratio by the use of medication like beta blocker. We have to give beta blocker to decrease the heart rate, in which we will optimizing oxygen demand supply because, as we know, blood supply to the heart come or during the diastolic phase. In tachycardia, the diastolic phase will decrease, and that will lead to decrease the blood supply to the heart, and worse, the case of ischemic heart disease. Second, send for more sophisticated investigation to evaluate the heart condition, just like echocardiograph. If the surgery can be delayed or postponed, the operation for 3 to 6 months after the attack of MI. In intraoperative period, avoid diastolic hypotension, avoid tachycardia, good analgesia. Postoperatively, we have to do ICU admission and oxygen therapy for 3 to 4 days. Second example is patient with cardiac failure when ejection fraction below 35 or underestimated cardiac failure is at highest risk. In a preoperative period, further investigation to assess cardiac function, review of medications. In intraoperative period, invasive monitoring, continue beta blocker and angiotensin converting enzyme inhibitors, avoid anesthetic with myocardial depression effect, treat arrhythmia, and treat any electrolyte imbalance. In postoperative period, ICU admission and positive inotropic infusion if need till oral consumption result. Third example of anesthesia strategy is patient with severe respiratory disease. The patient in which is with an increased risk of atelectasis because of reduced functional residual capacity. Many of anesthetics are with respiratory depressant effect, pain, and reduced mobility. In the preoperative period, good assessment, postpone surgery till optimization, bronchodilators and or steroid physiotherapy. In intraoperative period, regional anesthesia is better if possible. Avoid hypoxia and hypercapnia, delay extubation, good analgesia, good hydration, and avoid acid-base imbalance. Postoperative physiotherapy encourage early movement, good analgesia, ICU admission, non-invasive ventilation. Intraoperative management consists of 2 parts: monitoring during anesthesia and anesthesia technique. Monitoring during anesthesia. A minimum basic patient monitorings are 5. 1. ECG, electrocardiogram. 2. Blood pressure, non-invasive. Oxygen saturation by pulse oximeter. End-tidal carbon dioxide concentration and temperature. This is the minimal basic patient monitoring. While measurements of urine output invasive blood pressure, and central venous pressure are recommended for major surgeries. Ventilation monitor. We have to monitor inspired oxygen concentration, ventilation parameters, tidal volume, minute volume, airway pressure, and respiratory rate. 3. Delivery of anesthetic agents are also routinely used. This is the picture of monitor, which we see the ECG leads, pulse wave, CO2 concentration by capnograph, blood pressure, pulse rate, oxygen saturation. Anesthesia techniques. The techniques is either general or local anesthesia, depends on the patient condition, anesthetist experience, and the availability of certain drugs and instruments and machines. Anesthesia can be divided into local anesthesia, which include topical and infiltration, and regional anesthesia, which include peripheral nerve block, epidural, spinal, and intravenous regional or burst block. And general anesthesia, which is divided into total inhalational anesthesia, balance anesthesia, which inhale anesthesia, injectable anesthesia, and anesthetic adjunction, and total intravenous anesthesia or TIVA. In general, anesthesia is composed of 3 elements: the triad or triangle of anesthesia. First, unconsciousness or hypnosis by hypnotic or anesthetic agents, analgesia by the use of opioids, and muscle relaxant by the use of different muscle relaxants. Here is the triangle of anesthesia, which include hypnosis, analgesia, and muscle relaxant. General anesthesia steps should include induction of anesthesia, maintenance of anesthesia, and recovery from anesthesia. In induction, it is usually composed of giving anesthetic agents, muscle relaxant, and opioid as analgesics. So the triangle is anesthesia, muscle relaxant, and analgesia. Then airway must be secured by any techniques of airway management and ventilation techniques, which we discuss in the next lecture, inshallah. Anesthetic agents. Usually induction is done by IV anesthetic drugs called hypnotics, like thiopentone, ketamine, propofol, or etomidate. Induction can be performed by inhalational anesthetic or hypnotic agent as well, like halothane, isoflurane, or sevoflurane, but its main use in maintenance of anesthesia. So, an inhalational anesthetic agent mainly used as maintenance of anesthesia, but in some cases it's used for induction of anesthesia. In children or needle phobic adults, patient afraid from needle or cannula insertion, we sleep him with inhalational, then put IV line. Or risk of upper airway obstruction or difficult airway. This is the main indication for inhalational anesthetic agent induction. Rapid sequence induction is the use of premedication predetermined dose of IV agent plus rapidly acting muscle relaxant with application of cricoid cartilage pressure, and this type of induction is indicated in case of operation is being performed on patient with full stomach, as in emergency, or with delay in gastric emptying, as in cesarean section, or in order to protect airway from the risk of aspiration of gastric contents. Here we have the main hypnotic or anesthetic drugs used for induction, with their advantage and disadvantage or side effect. Main anesthetic drugs is propofol, thiopentone, etomidate, and ketamine. Inhalational anesthetic drugs also الهالافين, isoflurane, and sevoflurane, and with their in this schedule we see the advantage and disadvantage for each inhalational anesthetic drug. Second, after anesthetic drug اللي هو الهيبنوتيك, we have the muscle relaxant. Muscle relaxant are divided into depolarizing muscle relaxant and non-depolarizing muscle relaxant according to their mode of action. Hexamethenium or scoline is one of the depolarizing muscle relaxant. Because of a quick onset of action, it is used when rapid endotracheal intubation is indicated, as in full stomach or delayed in gastric emptying, to protect the airway from the gastric content aspiration. Also, hexamethenium is of short duration action, which make it useful in case of susception of difficult airway. Non-depolarizing muscle relaxant provide longer time of relaxation, and the way of giving these non-depolarizing muscle relaxant is by giving loading dose per patient's weight in kilogram, then top up doses if their effects ends before the end of operation. But usually these muscle relaxants required careful monitoring and reversal of their action at the end of procedure by agents like neostigmine or sogamatics. In this schedule we have the muscle relaxant agents and their mode of action and properties, advantage and disadvantage. Third, we have the analgesics. Analgesia is very important to the patient. Opioids are most commonly used analgesics, and of these opioids used in the intraoperative period is fentanyl and remifentanil. It's commonest opioids, but usually fentanyl is given by loading dose, the top up dose, while remifentanil is given by infusion. Morphine and pethidine are opioids, but usually used for postoperative analgesia. Paracetamol is one of the most commonly used analgesics other than opioids for intraoperative and postoperative analgesia. This schedule has a difference between fentanyl and remifentanil. This is the end of our lecture today. Thank you very much for your listening.